Good morning. My name is Krishna Vemalapalli, and today I'll be presenting a complex client case involving a 60-year-old male, Samarth, who experienced a right-sided ischemic stroke. Samar suffered a right-sided ischemic stroke 6 months ago and presents with a left-sided hemiparesis, neuropathic pain, and expressive aphasia that worsens with fatigue. He has a history of hypercholesterolemia and underwent triple bypass surgery 4 years ago. Recently, his GP diagnosed him with panic disorder, which is critical to consider in his exercise program, especially in relation to exercise tolerance, perceived exertion, and adherence. Samarth lives with his partner who works full-time, and Samarth, during the initial consultation, revealed that he is sedentary most of the time, has muscle weakness throughout the day, and feels bad that he is not able to do his part in household chores and would like to make it easier for his partner. In the consult, he reported that both his father and his grandfather had a history of CVD, and he, prior to his stroke, also had heart problems. Samar post-stroke uses a single-point mobility aid, and the medications include warfarin, Lipitor, and Diabex. Looking at Samar's client factors, physically, studies done by French et al. And Zhang YH et al. Show that hemiparesis and neuropathic pain limit strength, balance, and motor control. Aphasia affects communication, particularly under fatigue. A study done by Brady MC et al. Reveals that clients with aphasia may be frustrated when not being able to communicate efficiently. As this could pose a threat to exercise adherence, it is vital that we as EPs prioritize visual cues and clear demonstration to aid Samar. Psychologically, panic disorder may lead to exercise avoidance due to fear of bodily sensations like increased heart rate or shortness of breath. Research by Murtry et al. And Sardina et al. Supports this. Socially, limited supervision at home may impact adherence. Together, these factors demand a cautious, supportive, and well-structured approach to rehabilitation. In planning Samar's exercise interventions, I've integrated the highest level evidence to ensure safety, functional relevance, and mental health support. Post-stroke rehabilitation, Teasel et al. And Kim et al. Recommend aerobic training 3 to 5 days per week, 20 to 40 minutes per session at moderate intensity RPE of about 11 to 14. Resistance training is also prescribed 2 to 3 days per week using 1 to 3 sets of 8 to 15 repetitions at 30 to 50% of 1 RM. Functionally, we're focusing on mirror therapy to encourage recovery in the affected upper limb by reflecting movements of the unaffected side, and constraint-induced movement therapy, which strengthens the impaired limb by promoting use through controlled tasks. In Samar's case, we'll also use task-specific training, high reps, high-intensity exercises such as standing at the sink and gripping items, mimicking household activities like washing the dishes and loading laundry. These strategies are critical for building strength and coordination he needs to regain independence and restore his sense of contribution at home. For his panic disorder, aerobic exercise has been shown to reduce anxiety when kept at moderate intensity, 50 to 70% HR max or RPE 11 to 14. Samarth will be performing aerobic activity 3 to 5 times per week for 20 to 40 minutes using low-threat modalities such as spin cycling or recumbent bike. In addition, yoga and Tai Chi performed 2 to 3 times weekly for 45 to 60 minutes at his home will provide calming, breath-focused movements that support both physical conditioning and emotional regulation. These modes also reduce risk of dizziness or panic during uptight activity like laundry or standing at the sink, and may improve his confidence during ADLs. Lin X et al. Backs this up. Coming to his triple bypass, given his history, Anderson et al. Recommends aerobic training 3 to 5 times weekly, 30 to 60 minutes per session, at 40 to 60% VO2 max or RPE of about 11 to 13. For safety reasons, we will be using RPE. Alongside resistance training 2 to 3 times per week at 30 to 50% 1 RM. Exercise types such as walking, recumbent bike, and resistance band work are ideal. Importantly, we will avoid the Valsalva maneuver and use machines or bands to minimize strain. This protects his cardiovascular health while rebuilding functional capacity. Continuing with the clinical reasoning for Samarth's exercise prescription, this slide highlights evidence-based recommendations for his remaining secondary conditions: hypercholesterolemia, aphasia, neuropathic pain, and hemiparesis. For hypercholesterolemia, research by Exercise is Medicine recommends 3 to 5 days per week for aerobic training for 32 minutes or more per session using large muscle groups. Activities like brisk walking, cycling, swimming, or even ball games are advised. This aligns with the findings of Smart et al., whose meta-analysis concluded that each additional minute of aerobic training is associated with a 2.11 mg/dL increase in HDL cholesterol, a clinically meaningful shift as higher HDL is strongly associated with reduced cardiovascular and stroke risk. For aphasia, Hornish et al. Found that aerobic activities such as cycling or bike ergometer training 3 days per week at 50% of HRR in week 1 and progressing to 70% by week 3 over 30 to 60 minutes may promote neurochemical changes that support language recovery, especially when paired with cognitive tasks. As EPs, we can encourage Samarth to try out speech therapy to yield better improvements in his aphasia. In terms of neuropathic pain, a systematic review by Zhang et al. Recommends resistance training 3 times per week for 30 minutes, using a combination of joint motion, isometric strengthening with local vibration, along with relaxation strategies. These all are aimed at reducing hypersensitivity and restoring function. For Samat, I will incorporate gentle isometrics in a seated position using resistance bands, progressing towards dynamic movement with mindful cues to avoid exacerbating pain or fatigue. Lastly, for hemiparesis, evidence by Zhang et al. Supports aerobic training 3 to 5 days per week, 20 to 40 minutes per session at a moderate intensity RPE of about 11 to 13. Resistance training is recommended 2 to 3 times per week, 1 to 3 sets of 8 to 15 reps at 30 to 70% of 1 RM. Exercise modes should be supported like using a recumbent bike or walking with aids. For resistance work, I'll focus on functional movements such as sit to stands, transitions, and step ups, which directly target some goals of regaining confidence in the kitchen and doing chores like laundry. These movements mimic ADLs and will also help address his concerns about general muscle weakness and loss of independence. Together, these recommendations aim to reduce pain, support communication, and improve lipid profiles, restoring daily functioning, all while being sensitive to someone's physical limitation and psychological needs. To support Samad's adherence, I selected the top-rated behavior change techniques for each of his major conditions, based on recent systematic reviews and Delphi consensus findings. For stroke, the top-ranked and the most effective BCTs in the study by Robel et al. Include repetition and substitution, social support, and self-belief. From the study conducted by Venn et al., one BCT, namely excessive feedback, was shown to negatively impact stroke rehab outcomes and will be avoided. For panic disorder, traditional BCTs lacked robust evidence. Instead, I've adopted cognitive behavioral therapy approach, specifically interoceptive exposure. This involves safely recreating physical sensations associated with panic, like increased heart rate during cycling or breathing patterns in yoga, so someone can learn to interpret them as safe. Study by Mason and Asmundsen showed this significantly reduces anxiety and improves exercise adherence in people with anxiety disorders. As clients with panic disorder may not be able to differentiate between general exercise sensations and panic attacks, incorporating interoceptive exposure is not only valid, it's essential to unlock long-term adherence. For his cardiac history, the most effective BCTs are action planning and graded tasks. Conversely, I've avoided self-monitoring, biofeedback, and excessive health consequence education, none of which showed improved outcomes in this population. You can find the relevant statistical support for each BCT listed beside them on the slide. For the remaining conditions, I've carefully selected BCTs that are relevant to both evidence and SMART's goals, even where direct BCT studies are limited. Starting with hypercholesterolemia, while there is no evidence on measuring the effectiveness of BCTs that improve exercise adherence in this population, I thoroughly analyzed a study done by Kinnear et al., which explored behavior change strategies for individuals with hypercholesterolemia in relation to diet. Analyzing both the research and the facts about SMART from his referral to the initial consult, I selected instruction on how to perform a behavior, social support, and goal setting. For aphasia, I've applied evidence from a study done by Johnson et al., who examined effective BCTs in language rehabilitation and reports that feedback on behavior, goal setting, and behavioral contracts ensure the client stays engaged without overloading cognitive or communicative capacity. In neuropathic pain, direct BCT evidence is scarce, so I drew from musculoskeletal pain literature, specifically a systematic review done by Mead et al. The top BCTs include instruction on how to perform the behavior, demonstration and practice/rehearsal, and number 3, social support. Finally, for hemiparesis, I mirrored the same top-rated BCTs used in stroke rehabilitation, as well as avoiding excessive frequent feedback, which was shown to reduce long-term adherence in stroke rehab populations. In all cases, I've selected techniques that don't just reflect the literature, but that fit with Samar's real-life experience, making him feel successful and promote safe, lasting behavioral change. For Samat, my plan A incorporates 3 highly targeted strategies that address both his clinical profile and personal goals he expressed during our consultation. The first is repetition and substitution. This technique involves prompting the frequent rehearsal of functional movements and, where necessary, replacing less helpful behaviors with more adaptive ones. In Samat's case, this translates into practicing daily tasks such as sit-to-stands, dishwashing-like reaching motions, or laundry transfers as structured rehab activities. These movements reflect the exercises already recommended in his stroke and hemiparesis protocols, particularly task-specific training and functional resistance work. This approach not only promotes neuroplasticity and strength, but also reinforces his identity as a capable partner, which he's deeply motivated to reclaim. Next, I've included cognitive behavioral techniques, specifically interoceptive exposure. What makes CBT, specifically interoceptive exposure, so relevant in someone's case is that it targets the fear of physical symptoms, such as shortness of breath or a racing heart, which are common during exercise. These symptoms often mimic those of a panic attack. By safely recreating these sensations, though during the controlled sessions, CBT helps retrain his brain response, teaching him that these bodily cues are not dangerous. This isn't just theoretical. Mason and Asmundsen demonstrated that BCT significantly improves exercise adherence in people with anxiety-related disorders by reducing fear response. In Samad's case, it's not only appropriate, it's essential to break the cycle of avoidance and help him safely re-engage with physical activity. Finally, I've selected social support as it was ranked as one of the top 3 BCTs in majority of Samad's factors. Social support includes encouraging or arranging for others to be involved in supporting the person's performance of the behavior. In Samad's case, we can involve his partner in a few sessions or engage them to encourage Samad at home. In a case where plan A is not taken well, this will be my plan B. These are my references. Thank you for watching.